Welcome back to part 3 of the symposium on the cysts of the jaws, and in this section we're going to have a look at developmental cysts of the jaws. If you remember back to the initial section, we showed the list of cysts in the jaws, and the developmental cysts form a far longer list than the inflammatory cysts. In this section we're going to have a look particularly at follicular cysts and the odontogenic keratocyst, but we will very briefly mention some of the other cysts in the list that follow. But the two most important ones are those which are arising in the follicular tissues and the odontogenic keratocyst. So we'll deal firstly with follicular cysts. And these are cysts which surround the crown of an unerupted tooth, and they arise from the tissues which normally surround the tooth, that is the reduced enamel epithelium, which is covering the enamel after crown formation is complete. And if it is associated with an impacted tooth, that is, the tooth is still contained within the bone, we call it a dentigerous cyst. And if it is associated with an erupting tooth, that is, it's really pretty superficial and it's out into the connective tissues of the gingiva, then we call that an eruption cyst. So how do these develop? Well, the scenario of an impacted tooth is relatively common, particularly in relation to lower third molar teeth. But what actually happens to start the accumulation of fluid between the reduced enamel epithelium and the enamel of the crown is not clear. But it does happen. There is accumulation of fluid, and then the follicular epithelium, that reduced enamel epithelium, proliferates. So very often it doesn't just stay as the two cuboidal layers of reduced enamel epithelium, but it will become a thin stratified squamous epithelium. And once you've got that lining established, and it's proliferating a bit, and fluid is accumulating, you then have that whole cycle of a hypertonic cyst contents that wants to draw fluid in through that semi-permeable membrane. And then once the fluid is drawn in, the hydrostatic pressure rises and the cyst pushes out and grows and expands. Very similar to what happens in any other cyst. So what are the radiographic features of a dentigerous cyst? Well, you can see some examples here. We have in the left-hand picture an impacted and quite severely displaced lower molar, probably a lower third molar, and it is associated with a radiolucency. That radiolucency is quite well defined. For the most part, it's corticated. You can see a white outline to it, and it's surrounding the crown of this impacted tooth. It's quite large, so it's actually quite difficult to see where it starts and finishes. However, when you have a look at the right-hand radiograph, which is an occlusal of the anterior maxilla, you can see with this unerupted, impacted canine that it has again a radiolucency which is associated with the crown of the tooth. It is, for the most part, corticated as well as being well defined. And in this case, the arrangement of it in relation to the tooth itself, you can make out quite clearly. It looks as if it is attaching to the tooth on or around the amelocement junction. And that's an important point to notice for later on. Here's another example in this panoramic radiograph. Again, an adult patient with a restored adult dentition, and then this displaced and impacted lower molar tooth, perhaps again a lower third molar tooth. In this case, although it is a relatively large lesion, again you can see these features that it is a well-defined, largely corticated radiolucency that appears to be associated with the crown of the tooth and attaches to the tooth on or around the amelocemental junction. Some of these will grow to an appreciable size, and you can see in this CT scan slice just how expansile they can be. If left to grow and develop, they will resorb a lot of bone and can get to quite a large size. As far as gross pathology is concerned, this is what you see. And it's really very good for us if we get some good description from the surgeon about what the findings were when the cyst was opened and removed, because very often we don't get the tooth and the cyst together to have a look at histologically. So you can see, as we said, the relationship between the tooth and the cyst is very important. And in both of these, you can see it looks as if the cyst is attaching on or around the amelocemental junction, which is exactly where the reduced enamel epithelium would be attached to the tooth at the lowest point of the finishing of the formation of enamel. Histologically, again, you can see the things that you would expect from a cyst. And although this is low power, we do have a cyst which consists of a lumen and a lining and a wall. It is attached to the tooth at about the amelocemental junction. And there's some evidence of cell breakdown. There's some debris and cholesterol clefts here, but it doesn't look as if there's any real amount of inflammation within the wall of the cyst. And that's because it's not an inflammatory cyst, it is a developmental cyst. And so when you have a look at the lining, again we have lumen, lining and wall, you can see a relatively regular and thin epithelial lining. In this case it does very much look like reduced enamel epithelium. A fibrous connective tissue wall, really with very few inflammatory cells. Sometimes the epithelium is a little thicker than that. It is a thin stratified squamous epithelium. It's still non-keratinized. Again, you have the lumen, in this case containing quite a lot of debris, and the wall, which is fibrous and contains only a very scattered chronic inflammatory infiltrate. It is not an inflammatory cyst. So what about eruption cyst? Well, these occur when the tooth is erupting, so are effectively out with the jaws. In this case, in relation to an erupting upper incisor, you can see the coloration of the fluid which is within the cyst, and a relatively straightforward clinical procedure to allow that to open and hopefully then to erupt. You do get it in other circumstances. Again, you can see here that there is the retention of these primary teeth, looks as if they might be a bit displaced, and the erupting premolars are a little bit impeded by that, and there's a development of a cyst under that. They're not surrounded by bone, and this would again conform to the idea of an eruption cyst. For those that have got very close to the surface, when you have a look at the histology, you will find the same features. You'll have a lumen, a lining, and a wall, but the lining and the wall of the cyst can come very close to the surface oral mucosa. And that picture which I showed with the blue colour shining through is because the tissues really are very thin. So that's our follicular cyst, dentigerous cyst, and eruption cyst. And that with radicular cysts, they make up by far the most common. They make up about 85% of all odontogenic cysts. But now we're going to come to one relatively rare but very important cyst, which is the odontogenic keratocyst. So this is a cyst of the jaws, as you would expect, and it arises in the tooth-bearing area. And its characteristic feature, as you would expect from its name, is that the lining is keratinized, and it has a lining of parakeratinized stratified squamous epithelium. In this case, it arises from the dental lamina or its remnants, and it may well replace a tooth. In its pathogenesis, the dental lamina remnants, which are most common in the area of the retromolar pad round about the posterior aspect of the third molar tooth, they will grow and divide. We are still to this day not sure what the trigger for that is. Is there some underlying genetic abnormality? Is it triggered by trauma? We don't know, but this epithelium begins to grow and divide, and then in time it will break down in the center of the balls of epithelium as they grow, and a cyst will form. We don't very often see it at an early stage at all, but sometimes you get a little hint of it in a biopsy, and this was taken for something completely different. But you can see these little rests underneath the epithelium, and they have this keratinized little ball here, which may have been on its way to developing into an odontogenic keratocyst. So what about the lining? Well, it is parakeratinized stratified squamous epithelium, which is its characteristic feature. More common in males, mostly in the mandible. The majority of them as a single site in the lower third molar area, and quite commonly associated with an unerupted tooth. And that can give a little bit of confusion with a dentigerous cyst, and it's always worth remembering when you have a dentigerous cyst that on occasion it will be an odontogenic keratocyst. So here's our radiographic features. You can see a patient who really has very little in the way of restorative work, but we have a large radiolucent lesion. It looks as if it might have two compartments to it, which is extending from the posterior aspect of this lower 7. The lower third molar is missing, and in this case here you can see a much more dramatic example of a radiolucency that looks as if it's got a very scalloped outline, as if there's lots of multiple little pockets in this. And this is the classic appearance of a multilocular radiolucency of the jaws. And so they vary quite a lot in their appearance, this looking relatively smooth outline and corticated, to those which are very irregular in their outline. In other cases, you will see a classic multilocular radiolucency. This very definitely has a number of different compartments to it. The inferior dental nerve is running quite clearly down through the center of this. The lesion is well defined, it's corticated in areas. And another thing which is worthwhile noting in this point, when you take a radiograph in the other plane and as an occlusal radiograph, here you can see that despite the fact this lesion is really quite large, it extends from about the first premolar up to just under the sigmoid notch, it has very little buccolingual expansion. And that's very commonly seen in odontogenic keratocysts and can be quite a useful feature to help differentiate them from an odontogenic tumor such as an ameloblastoma, which very often has extensive buccolingual expansion, and we'll talk about that in the odontogenic tumor lecture. Histologically, what do they look like? Well, something like this. Here we have again lumen, lining, and wall of a cyst. In this case, the lining is a thin stratified squamous epithelium. The connective tissue is fibrous connective tissue with no inflammatory cells. It is not an inflammatory based cyst, it is a developmental cyst. And when you have a look at the lining at a little higher power, here you can see the slight change in the color. It becomes more pink on the surface. That's the keratinized layer. And the keratinized layer contains flattened nuclei, which means that it is parakeratinized. Very often, the keratinized layer has this rather bumpy sort of appearance to it, sometimes referred to as a corrugated pattern. The other thing which is very common in this, and is one of the features that we definitely look for, is a feature within the basal compartment of the epithelium, where the nuclei all stand up parallel to each other. And you can see this quite clearly in this example. We refer to this as nuclear palisading. And so that combination of parakeratinization and nuclear palisading of the basal cells is essentially what allows us to make the diagnosis of an odontogenic keratocyst. Now, as you can imagine, there are circumstances in which the cyst, particularly when it gets quite large, can get inflamed. And this is a diagnostic problem for us because what tends to happen is that the epithelial lining loses these characteristic features that we've just mentioned and begins to look like any inflammatory cyst. And so these inflamed odontogenic keratocysts can be very challenging from a diagnostic point of view. Now, even though they are relatively rare, perhaps only about 5% of cysts of the jaws, we do spend a bit of time teaching you about these because they are significant. And the main problem with odontogenic keratocysts is that they recur. Now, if you have a look at the literature, you'll find that the recurrence rate varies dramatically between different series. And in fact, some of the older series have very high recurrence rates indeed. But there are a few things which mean that that is more likely. The lining of an odontogenic keratocyst, because it's so thin, is very fragile. It's very easy to break it at surgery and leave little pieces behind. And more than that, it's not very well stuck down to the underlying connective tissue. So it has a tendency to separate, which means that, again, you're more likely to leave pieces behind. The other thing which you will see from time to time, which is shown in the picture, is that you get what are known as daughter cysts. Now, these are these little balls of proliferating epithelium with keratin in the center of them that are somewhat separate from the surface. They've probably budded off the surface, the lining of the cyst, but they are growing into the wall of the cyst. And again, they are relatively easy to leave behind if you're not careful during surgery. What is more, there is an association of odontogenic keratocysts with a particular inherited abnormality. Now, this abnormality is known as, well, there are a whole number of names for it: basal cell nevus syndrome, basal cell carcinoma syndrome, Gorlin-Galtz syndrome being some of the ones that you may hear from time to time. And these patients will have multiple odontogenic keratocysts, which have a great tendency to recur. They tend to have lots of daughter cysts. The epithelium is very active and it can be very difficult to get it all removed. But they also have basal cell carcinomas of their skin. Now, these occur on all skin surfaces. Basal cell carcinomas tend to occur in old people in sun-exposed skin, but in Gorlin-Galtz syndrome, or basal cell nevus syndrome, they occur on all skin. There are also skeletal abnormalities. That's frontal bossing. They tend to have a really quite large forehead, and others such as bifid ribs, so the ribs split into two at various points along their course, and other abnormalities within the cranial cavity. And so if you're to come across a case like this one in the radiograph where the patient has a number of these multilocular radiolucencies, well then you should consider basal cell nevus syndrome, Gorlin-Galtz syndrome in the differential diagnosis. And here's another example of a patient who has I think 5. There is one in each of the quadrants and then an extra one down in the anterior part. We do see from time to time occasional solid odontogenic keratocysts. That's lots of proliferation of epithelium with keratin, but no single cyst. And again, these have been suggested as having a greater tendency to recur. But the series in the literature are not large, and so the data is not particularly compelling. And here's another example of one which is filling the maxillary sinus in that case. And this is what they tend to look like histologically. No big single cyst, but lots of what look like these daughter cysts with keratin and other debris around about. Now, the variable nature of odontogenic keratocysts and also the tendency to recur has resulted in some people suggesting that in fact it might be a benign neoplasm. And what evidence is there for that? Well, we said way back at the beginning that odontogenic keratocysts have a higher tendency to proliferation within the epithelial lining. Does that mean they're neoplastic? Their higher rate of recurrence again might suggest that, and they have quite an aggressive and infiltrative growth pattern. We saw some of the radiographs which show that they can get to really very large sizes. One of the very supportive parts of that data is the relationship with basal cell carcinoma syndrome. And basal cell carcinomas are neoplasms. So why then are odontogenic keratocysts, because they result from the same underlying genetic abnormality, why do we not call them neoplasms as well? And we know what that genetic abnormality is. It is a mutation in a gene called patched, it's spelled PCTH, and that has been seen in this syndrome. The resulting discussions, which were extensive within the oral pathology community, resulted in a change in the 2005 WHO classification, where they actually renamed the odontogenic keratocyst keratocystic odontogenic tumor. And if any of you are looking at American textbooks, for example, that have been written in the past 10 years, you will come across this term. But we really were never particularly happy with that in the UK and thought that, well, some of the odontogenic keratocysts may be neoplastic, but we're not quite sure which ones they are, and so we don't have good diagnostic criteria for it. The end result was that in the most recent WHO classification, which was published in 2017, that the term odontogenic keratocyst was brought back into use, and that is our current terminology. It is a benign cyst of the jaws and is not neoplastic. What about some of the other cysts? Well, very quickly, I'm going to run through some of them. Lateral periodontal cyst. Now, this is the developmental lateral periodontal cyst. You can get cysts in the periodontium in a patient who's got periodontal disease, but they are inflammatory periodontal cysts, and I'm not going to say much more about them. But the lateral periodontal cyst occurs on the lateral aspect, strangely enough, between teeth, and the teeth are vital. It's developmental in origin. It's assumed again to be the rests of Ceres, although some people suggest the cell rests of Malassez, or even at times the reduced enamel epithelium. It's not really clear. Sometimes it's multilocular, and it's called a botryoid odontogenic cyst because it looks a little bit like a bunch of grapes. So here is the classic appearance of a lateral periodontal cyst. You see in this relatively younger patient undergoing orthodontic therapy that there is a radiolucency, almost a conical shaped radiolucency between the lower left 2 and 3. It's well defined, it's corticated. Histologically, it has a lot of the features of a developmental cyst. It will obviously have a lumen and a lining in the wall. It is lined by thin stratified squamous epithelium. And what sets the lateral periodontal cysts and botryoid odontogenic cysts apart is these focal thickenings in the wall, which we call plaques. Gingival cysts, which can occur either in infants or in adults, are probably arising from very similar appearance. The gingival cyst of infants arises from dental lamina rests very early in life, whereas a gingival cyst, it arises from dental lamina rests later on. And this is lined by thin, non-keratinized epithelium. So gingival cysts in adults tend to occur around on this buccal side of the tooth very often, whereas in the infants, it tends to be over the crown of the tooth before it's erupted, and they are seen as little white spots in infants. So here's the histological appearance of a gingival cyst. You can see it's not contained within bone, the surface epithelium is above it, and it is again lined by thin stratified squamous epithelium. Another type of cyst is the glandular odontogenic cyst. And I find this a very interesting cyst because you say, well, how when you've got odontogenic epithelium do you get glandular epithelium? And it does just show how amazing odontogenic epithelium is in the various ways in which it can differentiate. And in fact, in this case, you get cuboidal or columnar, respiratory, glandular type epithelium, along with the production of mucin. And this cyst has got duct-like or glandular structures within the wall. Very often it will have these focal thickenings that we see in the lateral periodontal cyst, but it's got goblet cells secreting mucin and these duct-like structures within the lining. These don't tend to be very common cysts, but when they do occur, they can be a problem because their recurrence rate can be really high. And here is another example of a glandular odontogenic cyst with these duct-like spaces within the lining epithelium. Lastly, the calcifying odontogenic cyst. Again, this was a cyst which was somewhat controversial because in the 2005 WHO classification, it was classified as a tumour. But it has now come back into the cyst classification in the most recent WHO classification, the calcifying odontogenic cyst. These tend to occur in younger patients, can occur in either the mandible or the maxilla, and the thing, as you would imagine from the name, is that they contain calcification, so there will be radiopacity within the cyst. And in this case, the cyst is lined by an ameloblastoma-like epithelium, and I know we haven't covered that. You may want to refer back to this in this case, and we'll maybe also talk a little bit more about this cyst when we talk about odontogenic tumours. But it has a number of different things associated with it. It has ghost cells, and it has dentine in the wall of the cyst. Sometimes, rather than being a cyst, it can be solid, and we call these odontogenic or dentinogenic ghost cell tumours. So here's an example. You can see a tooth which is displaced, the lower 7 is displaced, the crown of the developing 8 is displaced as well, and there is a radiolucency in the ramus of the mandible, relatively well defined but not corticated, and you can see the development of calcified material within that cyst. Again, these are very rare, and the tendency to recur is higher than you would expect for other cysts. So in part 4, we're going to go on to talk about non-odontogenic and cyst-like lesions, which you get around the maxillofacial region.